Welcome, and we're going to start our series, and I can see that a couple people have joined. And this is the second webinar in our series on data and measurement in youth mental health. I'm Alyssa Frampton, and I'm the coordinator of the CIHR Network Catalyst Grant in youth mental health. And I'm just briefly going to introduce the grant in the series before I'm going to hop off screen, and I'm going to hand things over to Matthew and Maxime, who are going to present today. And so, Catalyst Youth Mental Health is a network Catalyst grant that is a national networking and knowledge translation grant that aims to provide opportunities for the youth mental health community across Canada globally to engage, network, and share development and build collaborations around data and measurement. And through the series, we hope to better understand the current and future landscape around data and measurement in youth mental health, what's happening, where are the gaps, how are innovations filling those gaps, and then how we can move forward together. And so this can range from issues such as how to integrate data collection and evaluation in service settings, novel or innovative data platforms and opportunities, learning health system approaches, and so much more. So today we're going to talk about learning health systems. We're going to have Matthew and Maxime going to present about learning health systems 101, and I will hop back in at the end for questions. And I said I might forget this, but I'm not forgetting it to tell you that if you have any questions, you can pop them into the chat along the way. And also, if you are looking to have captions or also to have translation, you can just hit the translation caption button at the bottom of your screen, and everything will be fully captioned and translated. So over to you, Matthew.
All right, thanks a lot, Alyssa. So it's a pleasure for me to be with you today virtually to present on learning health systems and to present also with my colleague Maxime. So I'm going to share my screen and we're going to get going. So what we have in store for you today is really just an introduction to learning health systems. And we're going to speak in sort of broad general terms, but maybe during the discussion period, we can talk about how some of these ideas apply to the specific context of youth mental health. So just to introduce myself and my colleagues. So my name is Matthew Menear. I'm a professor at the Faculty of Medicine at Université Laval in Quebec City. I'm also a researcher at the VITAM Research Center for Sustainable Health, or the VITAM Centre de Recherche en Santé Durable. And I'm a health services researcher that does work in mental health services and also in primary care. I do a lot of work around interprofessional collaboration and integrated care, and also on person-centered and recovery-oriented models of care. And I'm presenting today with Maxime. So maybe Maxime, I'll let you introduce yourself.
Yes. So hello, I'm Maxime. I'm a professor at Université Laval, also with Matthew, and a researcher at VITAM Research Center on Sustainable Health also. And I'm mostly oriented onto my specialty and area of expertise are around psychometrics, evaluation, health system evaluation, and self-reported outcome measurement. So that's what I'll be presenting later, just after Matthew.
Thanks, Maxime. So really our learning objectives today are to sort of give you an introduction to learning health systems, describe some of their building blocks, and that'll be my part. And then I'm going to pass it on to Maxime to talk about how we evaluate within the context of a learning health system and talk about some of the measurement issues that we might face. So maybe the first thing to talk about is, why do we even care about learning health systems? What's problematic with the current health system that would make us want to put in place or move towards a learning health system? And the reality is that in health systems face many challenges. Among these challenges are things like the fact that there's a lot of variations in clinical practices. Not everyone receives the kind of quality of care that they deserve. And sometimes when there's variations in clinical practices, it's legitimate because people have different needs, and you want to tailor services to the person's unique needs. But in a lot of cases, those variations in practice are not warranted. and they're due to lack of knowledge, lack of resources, and other things. There's also systems face huge challenges when it comes to just communicating across teams, across the providers, across organizations. There's major collaboration challenges. There's a lot of delays in the adoption of best practices and new technologies. It can take years between the time some best practices are published and the time that they're adopted in practice. There's a limited use of data and evidence in health decision-making and quality improvement. And really, there's a pretty modest system performance despite the huge amount of cost that we invest in health and our health system. So these different challenges have led various experts across the world to promote this sort of vision of a learning health system, which is really an aspirational model for our current health system. So what is a learning health system? There's many definitions out there. I like this sort of description from the Alliance for Healthcare Communities because it's a little bit more lay language type of description, but they describe a learning health system as being characterized by continuous learning and growth. It brings together information from practice and research and feeds it back to teams in ways that are meaningful and usable to them. And this in turn leads to practice change that improves care. So the participants in the learning health system will collect, share, and use information in real time to guide care and improve decision-making. And this cycle of continuous improvement results in better client experiences, better health and well-being for individuals, communities, and populations, more satisfaction and joy in the work for healthcare teams, and a more effective and sustainable health system. So really this vision is describing a healthcare system that operates pretty differently than what we have right now, because we don't really have this sort of continuous learning and improvement in the system, and this sort of feedback of information back to teams. And I don't think we're really achieving sort of this quadruple aim or quintuple aim that's sort of described in the last part of this description. So I wanted to jump in and right away and sort of present what I feel are kind of the main building blocks of learning health systems. Like, how do we get from where we are today to where we want to be in sort of this aspirational learning system model? Okay, and I would say that the first important learning building block is this idea of a learning community. Okay, and a learning community brings together all the relevant partners that are needed to tackle a major system problem. And it's all the relevant partners that need to be involved in the learning and improvement process. So when we talk about all the relevant partners, it's really everyone involved in the learning community. So that would be your decision makers, your service providers, your researchers, your service users, families, and caregivers, and members of the public, citizens, community partners that are maybe not directly as part of the health system, and partners from other sectors. And the idea is that you're bringing together all the relevant partners that can tackle these sort of shared problems, and that all need to be involved in learning together. And beyond that, as part of your sort of core leadership, all those different interests and partners are represented as part of your decision-making group. And so contrary to what we have now in our system, where we have decision makers and service providers sort of leading decisions and making decisions, sometimes in consultation with other partners, sometimes not. In sort of a learning community and in a learning system, you really have sort of a governance structure and a leadership structure where all these different interests are represented and people are making decisions together. So what gets done in part of the learning community? And so what people do when they get together is they identify, they clarify, and they document shared system problems from different points of view using different types of information and knowledge. They're going to reflect critically on these problems together. They're going to establish a shared understanding of how to address problems and create value for all stakeholders. So not propose solutions that are only going to meet the needs and interests of one stakeholder group or one partner group, but really cover a wide range of interests and needs. They're going to share information and decisions, and they're going to take certain actions. They're going to identify which actions need to be taken and evaluate the results of those actions and oversee the learning cycle. The learning community and the leadership structure oversees the cyclical nature of this learning and improvement process. So what does a learning community require? But it does require leadership. Someone has to take leadership. But it also needs an inclusive governance structure. There needs to be a shared leadership and a shared way of making decisions and having people participate in a decision-making process. It usually relies on shared values. So people understanding that certain principles that are going to be guiding the actions of everyone involved. It requires funding mechanisms to ensure that the learning community is sustainable. So this is not like an organization that has some sort of recurrent funding, but a sort of a network of different partners, and ensuring that that network can continue to exist over time and function and operate becomes a more challenging issue when it comes to funding and sustainability. And there needs to be some sort of policies and principles around transparency and how to determine accountability. So, and you saw in my previous slide that, you know, researchers should be involved in this process. So this is bringing researchers closer to decision makers to be able to support decision making. But it also means that people who are service users, patients, caregivers, families are integral members of the leadership and the governance of your learning community and of your learning system. Okay, and so if you're thinking about, and because our presentation is short today, I'm not going to go into huge details on this, but I did some work with the Quebec support unit around a roadmap for partnering with patients, families, and caregivers in a learning health system. And so the link is here. You'll have access to our slides afterwards. And so this gives you some sort of like strategies for thinking about how patients and families and service users and citizens can be involved at different stages of the learning health system. So a second key building block is this idea of the learning cycle. So this is what we try to achieve in terms of the process, the types of activities that get undertaken in the learning health system. And in the literature, we tend to break down this learning cycle into sort of three big phases. The idea that we're going to, there's going to be some sort of clinical practice or some sort of health services that they're delivered, and you're trying to capture the data from those practices, from those experiences of care. So this is the practice to data phase. And then once you have access to the data, you want to be able to transform it in a way that's usable to support decision making. And so this is all the steps and activities that come with the data to knowledge phase. So capturing the data and analyzing it, visualizing it, turning it into data knowledge, sort of these knowledge products, guidelines and dashboards and this kind of thing, and using it to support decisions. And then once you have this information, it's about, okay, what do we know as the problem? What are the solutions to this problem? And how do we take the knowledge that we have and then go back and change practice and complete the cycle? And so this is kind of the learning cycle that you want to try to achieve within the context of a learning health system. And this all seems very straightforward, but the reality is it's really quite challenging to do. So for instance, like when we're talking about the practice to data phase, sometimes the data that we collect as part of our routine data collection is not really what matters to people or matters to some stakeholders. And it sort of doesn't align with the kind of broader system objectives that we have. And a lot of times our data systems, they don't really speak to each other. And so it's really difficult to aggregate data and pool data together. From the data to knowledge phase, sometimes we have access to lots of data, it exists out there, but we don't have the resources and infrastructures to properly analyze it or to share it and to make sense of it. And so there's a lot of waste that happens in terms of wasted opportunities to be able to profit from having all of that data available in the system. It happens fairly regularly that researchers either aren't able to produce knowledge in a timely way, or they produce knowledge that's important and usable, but they don't really take the necessary steps to translate it into practice. And so there's been a whole field of implementation science and knowledge management around how to move from, taking knowledge and moving it into practice. And the last step is, sometimes the knowledge is out there, but decision makers responsible for changing practice or providers are choosing their change strategies not based on any data or any of the evidence that's available. And so we get these sort of piecemeal strategies that are not necessarily going to be the most impactful for producing practice change and having impacts on outcomes that matter to people. So what we're trying to achieve through this learning cycle and in a learning health system sort of vision is going around this cycle in a much more rapid way, in a much more connected way, having the expertise necessary that's embedded within the system. And so that it becomes easier to sort of transition from one phase to the next, making it a part of the routine ways of doing things, part of the culture. The way we do things around here is to learn and improve. And it's just part of the routine way of working within the system, and that we can continue this cycle again and again and be really in a cycle of continuous improvement. So the third building block relates to having the digital technologies available and the data infrastructure. Okay, and so digital infrastructures are really essential to be able to capture data and feed it back to the system to inform decision-making and practice improvements. And the reality is that we live in an era where technology is omnipresent, and there's lots of digital systems and platforms and technologies out there, but they're often not really connected in a way that's going to support the learning health system. And so I can bring it back to this idea of the learning health system and the learning cycle. And when you talk about practice to data, there's a range of different technologies that are useful here. And there's a systematic review by Coates that came out recently looking at the different digital technologies that are part of learning health systems. And so this slide is really informed by that. But if you think about how we capture data on clinical practice in the system right now, well, there's things like electronic medical records or electronic health records that clinicians use regularly to capture data on their clinical interactions, clinical registries, there are patient portals. There are also the systems that researchers put in place to capture information, so online survey systems and other data platforms. We even capture data on our own using wearable technologies and through our mobile applications. And then we can store this kind of data in these warehouses, repositories, and data lakes. So these technologies exist, and they can be really useful at that phase of the cycle. Once we have access to data, we want to be able to aggregate it and make sense of it and analyze it. So there's all sorts of different data analytics software that we can use for that. And increasingly, we're seeing a lot of AI systems being introduced in learning health systems that are going to take advantage of things like natural language processing, machine learning, algorithms to make sense of a situation, do some predictive modeling, and so on. And there's also sort of technologies like dashboards and visualization technologies that we can use to really present a clear portrait of what the data is telling us to be able to inform our decision-making. And then once we're ready to be able to move some of that knowledge back to practice, well, there are all sorts of online and digital clinical decision support systems, databases for clinical guidelines, websites where we can find tools and resources to support practice change, any sort of platforms that support communication and portals, communities of practice, and even things like audit and feedback systems to be able to really inform practice and sort of motivate changes. So there's all these different technologies that exist, but in a lot of cases, they're not really connected in a way that really support the vision for a learning system. So a fourth building block, okay, we've gone through three, this is building block number 4, is a shared vision on how to create value, right? So you have a learning community, you have data, and you want to put in place a learning cycle, but to what end? What are we trying to achieve? You know, these are the kind of questions we really need to ask to understand how we're going to create value for members of the system. You know, what outcomes are going to matter to everyone? And what does success for our system look like from different points of view? And so these are the key questions that we need to sort of come to grips with when we're meeting together as a learning community. And the leadership is trying to define, you know, what is important to achieve through this collaborative work. And I think that there's a consensus that things like the quadruple aim and then quintuple aim, which are sort of these like broad frameworks for large, broad system objectives, are things that can help us think about, you know, some of the main objectives that we should be seeking. So thinking about how do we achieve better health, How do we achieve better care, better care experiences? How can we be more efficient in our use of health resources and reduce costs? How can we support teams to find meaning in their work and to be themselves have good experiences delivering care? And then how do we consider things like equity, diversity, justice, even things like reconciliation in the concept of this system? And so this is going to help us provide some ideas of like a broad system goals, and also what kind of things we really want to measure to be able to know if we're achieving the success that we want to achieve as a learning health system. And this will make the link to what Maxime is going to be presenting in the second part of this presentation. I raise it right now, and Maxime will come to it, but this is a good starting point to think about this, is what are the different patient-reported outcome measures and patient-reported experience measures that might be important to start measuring as a learning health system, because oftentimes these measures are not being captured in the system as it stands now. So the last building block really relates to the different system supports and accelerators that need to be in the environment for the learning health system to really flourish and function properly. And so this is all the other types of infrastructures and systems and resources and supports that need to be available. So things like having the right partnerships and experts available in the system, having the right communication platforms, and making sure that at a policy level or at a legislative level or at an organizational level, like the policies are in place to support the work of the learning health system and don't act as barriers to what people are trying to accomplish. Making sure that the funding is available to achieve the learning health system, and that the different ethical frameworks are in place as well to be sensitive to some of the issues that come up in terms of, you know, data sharing, protecting confidentiality, protecting privacy, but also allowing information to flow in the system. There needs to be some sort of reflection around the ethical issues of putting in place learning health systems. And sort of a key message I want to throw out is that, you know, we have this idea that every system is perfectly designed to produce the results that it's producing. So if we want our systems to continuously learn, improve, and achieve better results, we really need to rethink how our systems are designed and the supports that are available to us. So even if we have a group that's really motivated to put in place learning health systems, we need to think about the ecosystem and the environment that's going to be, you know, that in which that sort of system is going to be running, to make sure that everything is aligned to achieve that vision. So I want to finish sort of by talking about sort of like what is really different between, you know, the traditional health system or what we see right now in the health system and sort of the learning health system. And so, and this is going to just sort of recap some of the things that I've said, but from a leadership and governance standpoint, when we think about what's happening in the current system, we have a lot of decision-making happening in silos. There's a limited amount of power sharing, and there's a limited amount of patient and public involvement. Whereas in a learning health system, this is happening in a much more participatory way. There are more people involved in decision-making, and patients and the public are seen as integral partners in the governance of the system. When we think about learning and improvement, currently, as it stands now, there's really a limited use of the data that's already captured in the system. Learning and improvement is often not prioritized. Usually it's direct care that's prioritized, and people just don't make the time or take the time to think about what needs to be improved. There's a real slow uptake of innovations, and researchers are often disconnected from the spheres of decision-making. In a learning health system, you have learning, which is really ingrained as part of the culture. And quality improvement is part of the routine of how we function as a system and occurs very rapidly. Researchers are embedded within the system and they co-design projects with system partners. From a data and technology standpoint, currently data that's captured, we capture what's easy to capture, what's easy to measure. And a lot of our infrastructures are not really connected, in which we're really limited in what we can share in terms of information. Whereas in a learning system, our infrastructures are much more connected and interoperable. And the data infrastructures that we put in place are put in place specifically to help us achieve the different phases of the learning cycle. And finally, in terms of system goals, right now we have a system where the goals are determined by a select few. And our data collection is often misaligned with some of the goals that other people could have. And so in a learning health system, you have system goals that are really aligned with the interests of a broader group of partners and with the data collection systems that we have in place. So that gives you just some broad strokes in terms of what's different between the current system and the aspirational learning system. So I'm going to stop there, and I'm going to hand it off to Maxime for his part, and we'll take questions after Maxime has finished his presentation. So let me stop my share, and Maxime, you can take it from here.
I'll activate my mic. You hear me well? Yes? No?
Yes.
Screen is lighting green, so I suppose I'm okay. So thanks a lot, Matthew, for putting the table so expertly. It will help my case a lot. So now you have a general understanding of building blocks. My presentation will be just a little different, much more pragmatic. So the goal of my part is to help you figure out. So you have a team, you have a program, you have an intervention, you have something that you want to think as a learning health system. How do you do it? So this will be this will be the subject of the presentation today. As you can hear, English is my second language, so be patient with me if I stumble on my words or have difficulty finding something. Okay, so just a general acknowledgement. My salary is funded by the Fonds de Recherche en Santé du Québec. This is why I'm a junior 1 researcher. This is why I can have time for research and I have time for knowledge translation activities like this today. So I want to acknowledge this and no conflict of interest. So the first objective of this presentation will firstly to introduce logic modeling. This will be the tool to help you at any point, at any level in a health system. If you want to think a little more critically about how do we measure and evaluate, this will be the tool that will help you. This is my main weapon for this kind of work, and you'll understand why. So I'll share with you the thing that I use when I'm catapulted on the team to help with its evaluation. So you'll see that in a minute. And maybe the objective too, I'll maybe cut it short or cut it entirely if we don't have time, but I want to concentrate a little more time to the first objective, and we'll see where it brings us. So this is my main tool. So because the objective of the presentation is to give you tools and things to help you plan and think, you'll have QR codes to the documentation. So when I'm talking about something, you'll be able to get to it really easily with the QR code. This is the guide to using logic modeling to bring together people for planning, evaluation, and action. So this is the main thing that I use with teams to think about what the intervention, what the program, what the system is doing. So if you start from an intervention from a program and you try to think about what it's doing. If you think probably with your line of work, you can think about any intervention that promotes self-management. Can be quite tricky to put together. Okay, what are we really doing? Where are we acting? And how do we measure outputs? So this is the kind of tool that helps you. So you'll have on the left the assumption. This is usually your theoretical underpinnings. So what is supporting what you are doing in terms of knowledge? Your input will be what will you input in your work? Who will be the source of input, or what will be the source of input in your activity, your program? Your activities will be what your program what your intervention, what your system is doing. So this is so you have an example here, and we'll have more specific examples, so that will probably help in the later slides. You'll have outputs, so this is general understanding of what the output of your activity are doing. After that, we are getting to outcomes. So what will consecrate, what will focus on for this presentation is outcome and impact. So what are your input, your outcome? Your outcome are generally measurable, or you are able to be estimated, and your impact is usually not really measurable, or with a causal link that is really weak. So you know that this is the general impact that you want to have, but you are not able to measure it as the part of your intervention or system. So this is just another example that you'll find. It's this is a generic one. I think I'll skip it and give you something just later on that is specific, that I've built myself, so that you'll be able to see in the real world, for lack of a better term. This is when you are at the table with people, with stakeholders, and you are thinking about what you are doing. This is just, you build a little table like that, and is to bring ideas together. So you chit chat about resources, activities, outputs, outcomes, impact. So you list everything. You do not try to build your logic model at first. So you're just listing things. And when you are focusing on outcomes and impact, an acronym that can help you is the SMART acronym. So your outcome need to be specific, measurable, action-oriented, realistic, and timed. So if you see the example in the table that you have on the top of the table, you can see that you have all these listed there. This is one checklist that I use specifically for outcomes and impacts. It's asking general question. So if you look at it's indicator of quality of choosing your outcomes and impact. So you have it cuts a little bit into what the pillars that Matthew was presenting before. So you'll see things that are, so learning health system, when Kellogg planned that document, it was not really in the scientific literature at the time, or really a fringe thing. So it is linked, but not directly linked, and you'll see the learning health system later on. But when you look at what are quality criteria, you can see so it's really specific and helpful for your team just to think about, do we know the source of data? So if somebody at the table bring an indicator, so you can just ask the question to choose as a team if you have the source of the data, or if you have the technical assistance required to extract it, or things like that. So it undercuts a little of what Matthew was saying before, where we need to choose the indicator and outcome strategically, so that you can be it can be helpful to bring it to the table to take decision later. So this is the specific example that I want to share with you. This is one that I've built for an intervention about patient. It's patient recorded data. So it's an intervention about a portal where we put integrate patient recorded data, and it is PROM, so patient reported outcome, but also accelerometer, saturometer. So it's for chronic disease management. So you can see here that you have an input, which is integration of data. You see activities, which are the source of the data that are inputted. You can see output, where you have device data, platform log, and things like that. After that, you can get to outcomes. This is specifically what we choose to measure. So these are all outcomes that can be measured, that have time constraint, and that are actionable. So you can see them there, and you can see that the impact is much more of a loose objective, so far-fetched objective, improve health status and monitoring of chronic disease. So it's more general. So if you are, and I'm sure you are, brilliant, intelligent, and thoughtful, you must have thought, but what about learning health system? We just saw that we need to think it as a circle, to do data and impacts, to take decision, bring them back. So this is how you bring it together. This is the same kind of, I presented in 2 slides just because it's easier to see it as a line than seeing it as a circle. But it's the same logic model with the context added at the on the underside. So you have the problem, you have input, outputs, outcome or result, and impact. And you have the context. So you take your results, you consult the stakeholders, you take decision, how do my outcome, my measurement, my data, what does it say and how it impacts the context where the intervention is located, or the program, or the department, if you want to think about larger entities. And how do we adjust? How does that impact our initial problem? And let's do the cycle again. So rethinking about, or do we need to change our input, change our activities, change our way to measure data? So you need to really think about it in a circle way. This is an adjustment that was done to the logic modeling process by the CDC. It's a little bit more, it's more in a circle, it's in a circle manner, but I have a small critique of that process. Just if you stumble into it, if you're interested in logic model, you'll see this figure pop up, or this guidebook pop up also. And what is not helpful about this process is that you do not go back to describing your program. So it's not thought as a circle. It is portrayed as a circle, but it's not thought as a circling evaluation process. So if you are interested and get into it, just think about your process. Do not stop at the step 6. You need to so I don't like steps because of that. The step 6 is the step 1 that you need to start back, or more the step 2 to adjust your logic model and start back. So yeah, so just wanted to present that. So I just want to be sure that I'm good on time. So okay, that's good. So Matthew introduced you about patient-reported outcome measurement, or patient-reported experience measurement. This is a right place to start. When I'm contacted as a specialist to help a team in the last year, I would say it's always to implement a PROM or a PRAM, a patient-reported outcome or a patient-reported experience measurements. So I'll try to introduce it to you and try to get the basics to, okay, you want to start, where do I start to choose one, or to evaluate the quality of one, just so that you're not completely unaware of how to think about this. So just as a basis, patient-reported outcome measurements are health status reports that reflect patient perception of their own health without any intervention from a clinician. If you think about PRAM, patient-reported experience measurement, so you just move to you move out of health status. You are thinking about experience, so satisfaction, communication. So how does the person interact with the system? And we have a lot of literature on effective implementation of PROM and what it does. But you see the list here, and it's really helpful for a system to have the perspective of a patient in their decision making. So just a little more theoretical basis about PROM and PREM. They start from a subjective experience. So really, the quality of a PROM or a PREM is based on the quality of the description of that experience. So if you have weak qualitative literature on the subject, there's no possibility to have a good PROM or a good PREM about it. So it's really the basics. So if you are knowledgeable about qualitative research, this is always helpful because you'll be able to be sure that the subjective experience is described in a way where you can provide a measurement on that subject. So this is the step to this is going to the next step where you build a description and the measure creation. So you build items, you build scale, and after that, you get to the psychometrics. So just understanding how the measure your scale or measurements really measure what the subjective experience of a patient or a person is. So just some example that you probably know, but SF36, which is a general health status measurement. Oh, my French scaling is there. Sorry, I forgot to translate it. You can see also the global health from PROMIS, and something that is a little harder to measure, like patient activation, which is the first theoretical step into behavior change. So is the patient just activated to do a change? So you can see that the items are longer and really easier to mess up. So you need to really understand well what you're trying to measure. So this is how you evaluate the entirety of the quality of a self-reported measurement. So the good thing is that usually when you find a measure on a scientific database, or that a measure is well known or well used, you'll have most of the things here are already answered. So you'll find literature on reliability, on responsiveness, on validity. Where I want to focus a little more is the content and face validity. You have a little, so if you want to use a PROM or a PREM in a new context, you have this is the place where you need to ask yourself questions. You need to be a little knowledgeable on how to use it in a good manner. But if you are really interested in PROM and PREM or self-reported measurement, as I am, this is the entirety of my expertise. It's hard to get good on everything here, but it is the way to evaluate a PROM accordingly. So if you are interested in introducing one, you can see the table 6 on the left side was a Delphi on what was important when you are choosing a PROM. So it's mostly experts, clinical experts, and so a group of experts that took the decision. And you can see at the top of the scale, of the top of the table, you see patient comprehensibility. This is one of the things where you can have problems, and because you are interested in a pediatric population, this is a place where you can have significant difference, because a child would not really understand the same way as an adult. So if it was a scale general development, general population development, and you are using it into another population. This is a thing that you can do. It's cognitive interviewing. It's mostly just somebody answering a scale or a survey or a measurement. In French, we would say the direct translation is I voice, but it's just voicing their inner voice. So saying why they take that decision and what they understand. And it's an entire process, but it can help a lot with, is my scale really doing what it should be doing? And you have an example at the bottom, the pie chart. You have how it was how the same item overall during the past 4 weeks. How much difficulty did you have with thinking clearly and solving daily problems? So you have on that pie chart how it was understood. So what was the main thing that the person thought the question was asking? So you can see that with the same items, you can have several different understanding and interpretation. So it really helps to understand well what your scale is doing. And I'll finish with this. If you are interested in getting, so this is another step that you can go in after choosing a prom or a pram, into how you ensure that your prom or pram is inclusive and equitable. This is a really good paper with actionable things that you can do if you want to improve diversity, cultural needs, literacy and health literacy, digital inclusion, what you can do actually to improve that. This is a really good paper that I wanted to give you as a tool also to take decision on this. So my key messages for the presentation today is that first, for my first objective of the presentation was that to show you a little bit logic modeling and how it can help thinking about evaluation, measurements, and take decision as a group, and what kind of question you can ask to be sure that you have the resources, the infrastructure to collect that data, and that it will be helpful. Also, how to think about logic modeling in a learning health system way. And for self-report, what I wanted to be sure for you to understand is that a prom is not exempt from bias. You can have a lot of bias introduced by a prom, even if it's widely used and really well utilized in your context. You can still really easily introduce bias in your measurement, and that you need to have people involved at every stage of design and choice to ensure the consistency of your measurement experience. So thanks a lot, and I think that was not too long, so we'll still have 10 minutes for question and general sharing. Thanks a lot.
Thank you so much. I'm going to come back on video. Thank you so much to you both. It was wonderful. I'm going to ask that anybody, if you have questions, can you please put them in the chat now? I have a question as well that I will ask in a moment, but I'm going to give it a second. One question is, how do we who decides on what good outcomes are from a learning health system, and how and what we are going to want to measure?
Maxime, do you want to take a first stab at that, and I'll maybe follow up after?
Yes. So this is quite literally the question that I've been asked the most. So it's really complicated. So you need to, using the logic model is usually a context or pretext just to get people together to think about things. Where you want to probably extend a little more from the basic interpretation that I showed is to have a different level of measurement. This was not part of the logic modeling because usually I'll bring people to that point because of using this. You see it with impacts where you have really distal outcomes and measurements, and you see it with outcomes where it's more like it's usually near your objective or your activity. But you can think about process outcomes also. In a learning health system, this is really helpful. Just thinking about, okay, we are implementing for an intervention or program, we are thinking about our entire process and what it does, but also you can think about what resources it takes, what is the cost of getting these people together to take decision and to have time where you need to go back to evaluate and integrate the data that you've collected. But you should always take into consideration your entire context to choose, and to have things that have different aims. So if you, for the intervention that I showed you, there were a lot of outcomes, mostly because it was in a research perspective. But usually what you want to have is maybe one good patient outcome, one good clinician outcome, so you can focus on people, on category of people, and have something for your process to be sure that the process of your evaluation goes well and that you can follow what you're doing. I'll leave maybe Matthew give more insight if you have anything to add. This is usually the way I try to categorize and choose as a group.
Yeah, so let me just follow up on what Maxime said by saying that typically your leadership group of the learning health system is going to be deciding on what sort of outcomes are going to be prioritized. And you're going to want the decisions to take into consideration different perspectives. And so, and it's often not the case that a single measure or a single outcome will meet everyone's needs. Usually there's going to be a collection of different outcomes and measures that you're going to want to, keep track of to know whether the learning system is achieving its results. But I think you want, let's say we're talking specifically about youth mental health, like you want youth and their families or their parents, caregivers to be involved in decisions about what's being measured, so that we do keep track of measuring things that are important from their point of view. If the measurement involves things that are collected from service providers should definitely be involved in those discussions around what's being measured. And any other relevant partner should be involved in those kind of decisions. It's really a situation where this is a perfect opportunity to make a joint decision where different partners contribute to the discussion, and you are able to better understand what are the different interests and priorities of different partners, so that you can propose a series of measures that are going to meet those priorities. And so I really think that this is an occasion where, choosing what you measure and understanding what your system is trying to achieve is one of the main areas where it really helps to have an inclusive participatory approach to like leadership and governance, and you have your main partners involved, and youth and their families should definitely be a part of that. So maybe I'll stop there. There's a few other questions. There's a question about what about proof of evidence needs for both tangible and intangible data that is governed by controlled instruments and measures. Do you want to take that, Maxime?
I am really not sure I understand the question. So maybe if you have anything, or if the person can voice,
yeah,
maybe my English is maybe lacking on this.
Alyssa, are we able to like open a mic for people or not?
We can't open a mic for people, but Julie, if you want, you can expand in the chat.
Okay.
And I will say there's a couple, maybe we can just continue with a couple other questions, and Julie, if you want to expand in the chat.
Perfect. So there's a question from Jay around how do we balance out the need for common goals and outcomes across an entire network while also allowing for local realities, which may not be common, but are still really important for this cycle and culture to take root. So I think the idea is that like we tend to think of a learning health system as like a really big thing, And I think that, within our networks, within our health system, there's actually room for multiple different communities to exist. And it really depends on what kind of problem you're trying to tackle at a time. And sort of like, you kind of want to have a learning community built around a key focus area or a key problem where everyone's kind of working together to achieve a common goal. And so that's where it becomes kind of like, it becomes possible to sort of define what the common goals are when you have that sort of core group together. And you might recognize that, okay, we have within our system these subgroups that have different needs. And so there may be needs, like a need for like these sort of sub communities or subgroups where you try to implement learning system principles, but at a smaller scale. And you're able to tackle problems that are really focused to the needs of those specific communities. So it's hugely challenging to put in place a learning health system on a grand scale. And more realistically, what we have is like sort of these network of networks or these system of systems where you have these smaller communities that are sort of sometimes interconnected with larger communities. So I would say that's how you can try to achieve that sort of balance, because normally there's a broad range of different interests in the health system, and it can be difficult to reconcile all those different interests. There's a question here from Jay. So Cliff, are you able to expand on developing a community that authentically engages with patients, families, and caregivers? What are the challenges have you run into around it? So I would say that there's a lot of work around this. We're probably short on time to go into detail on this like right now. There are certainly challenges. I think that if we think about the way the health system is designed right now, there is a certain level of patient and public engagement. There's a certain level of consultation that happens, but we're far from the vision that is promoted by a learning health system. And so, but there's been a lot of work around, how to engage patients and families and citizens in health systems more generally. There's various mechanisms that can be put in place. And so I think the key thing is that you want to involve patient and partners at key steps in the process. So determining what the key problems are, what the key areas of focus should be for the learning health system, trying to understand how to measure those things and what measures make sense and are meaningful to them, having them be involved in interpreting the information that's generated by the system, and so that they're partners in the proposal for the different solutions that are put in place. And they're also involved in implementing those solutions and evaluating the impacts of those different actions that are taken. So there's many key opportunities for them to be involved. And I think what you mentioned about sort of authentic and meaningful engagement, we've learned a lot in research around how to do that. I think from a system level, we're learning more about how to do that. And it's really about creating an environment where, those voices are valued and there's supports available to make sure that they can engage in a meaningful way. So, but I think that this could be a whole separate webinar where we go into this in detail.
Yeah, and I just want to add is that even if you are interested in getting into, for example, patient-reported outcome and patient-reported experience, if you're not well tuned on what people want or what people aren't interested in filling and how this data is used, you'll be surprised that you will have any participation, because it really needs to strike a chord with the population that you are trying to measure, to be able to really have good participation and uptake. So so you need to have a good description of the process and the context. If you're not well versed into what is needed in that community or that practice, you'll get into a wall.
So I see that there's a couple last questions or comments in the chat, Alyssa. So maybe we can take those and then sort of like wrap things up for today.
Yeah, that would be great. Yeah, thanks.
So I'll start with Carolyn's question. So she writes, when developing a learning health system, do either of you have experience implementing these learning cycles in Indigenous contexts? If so, what ethical challenges have you experienced, or how have you enacted First Nations principles of ownership, control, access, and possession? So it's really an excellent question. So from my experience, I have not been involved in implementing this with Indigenous partners, but I know that this has been done. And so I know that these kind of discussions around learning health systems have been made with different Indigenous groups, Indigenous partners, I think in Canada and internationally. And there is some evidence coming out about this. So I can't really speak to all the ethical challenges, only to say that, the importance of working with members of these communities in a respectful way, in a way that recognizes different forms of knowledge becomes all the more important, and that the building of relationships and building of trust becomes really crucial to be able to put these kinds of systems in place. And so, there are researchers who do, research with Indigenous communities, and it's really a way of doing research that can be very different than, what we see out when we work with other types of partners. And so I think that when we build learning health systems with Indigenous peoples, Indigenous communities, there's a lot of co-learning that has to happen during that process. So again, I can't speak to direct experience, but I think that there are papers. I think I've seen a recent paper on this, so I would encourage you to sort of like do a little bit of searching, because you should be able to find a paper or two on learning health systems with Indigenous communities in Canada. I don't know, Maxime, if you have any experience or not. I don't.
No. I can tackle the question that I was not understanding. There was some clarification. Perfect. So I can try to tackle it. So from what I understand of the clarification, it's mostly about identification of prevention intervention or preventive intervention, if I understand well, because proof of evidence, I'm from the systematic review and meta-analysis methods. So when you talk about proof and evidence, maybe it does not resonate the same way as me. So I'm not really sure I understand really well this. But so what you want to have is identification of the best intervention before the start. This is not part of a logic modeling process. You usually want to have an expert in the domain with stakeholders deciding which things to implement or try. But where the logic model can help is to, if you know what the intervention should be doing, or where it should improve things, or what kind of activity should improve the process in any way, that's where you need to have where a modeling can help you, because you'll put in that model things that are supposed to be moved by that change. So outcomes, you'll choose outcome to be able to evaluate that process. And if it doesn't work, or there's no moving, you can look at, is it the measure problem? Is it the sampling problem? Is it so you can tackle different problem in the context part. So what is happening there? And if you have a novel thing that could be implemented, so you can switch things up and change for another. So that's where a logic model can help, but it cannot help in choosing the best intervention. That is another kind of process. So I hope I understand well.
No, I think that's great. Thank you so much. Thank you both again. This was wonderful. So grateful to have had you both to present. And thank you to everyone for participating in the questions. I think that was actually quite a animated discussion. So great. And yeah, if you have any other questions, or if there's anyone who has anything else they'd like to add or share, please do email me or write in the chat, and I will pass anything along to Matthew and Maxime. Okay, thank you again, and have a great Friday and great weekend, everyone. Bye-bye.
A small but really active group that we had. Thanks a lot for asking a lot of questions.
Absolutely.
That was good.
Thank you.
Thanks very much, everyone.